let's look at the pathophysiology of chronic fatigue syndrome. Now, broadly, you can see there's loads of things happening here. We've got mitochondrial dysfunction. We've got to look at cardiovascular system and respiratory system. We've got to look at mitochondrial dysfunction leads to brain fog. We've got neuroinflammation, systemic inflammation, autoimmunity because of immune dysregulation is one of the criteria. Neurotransmitter dysregulation. Now, we will be able to intervene here quite well when we recognize which ones. Neuroendocrine dysregulation. This is so closely linked to trauma. Why? Because we'll see later strong association between trauma and chronic fatigue syndrome as well. And we know that trauma impairs the HPA axis. This is where we've got to take into account cortisol and the risk of other inflammatory autoimmune dysregulation. So this neuroendocrine dysregulation also feeds into the overall systemic inflammation. Then gut-brain axis. You'll often find that patients with chronic fatigue syndrome will complain a lot of gut issues as well, whether it's diarrhea, abdominal cramps. We'll see in POTS that comes in, and we'll see why that comes in as well. Then we have central neuronal sensitization. This is one of the key pathophysiologies behind fibromyalgia. On day 3, when we look at fibromyalgia, we look at the specific pain pathways, and we will see pain physicians usually work along the periphery as best as possible. That's why with spinal stimulators, of course, they look at ketamine at the NMDA aspect. But as psychiatrists, we're able to intervene at 2 crucial areas to make a big difference. So again, strategy remains the same. Then we have autonomic nervous dysfunction, exactly the same strategy because central neuronal sensitization, autonomic nervous dysfunction, we're still looking at the pain pathway in a way along with the autonomic nervous system. So this is broadly the pathophysiology. So let's take a step back and just think about the domains. Firstly, we know it's PEM. It's post-exertional malaise. Now, one of the ways to differentiate between depression and post-exertional malaise or fatigue is generally, now this is not as clear-cut, but generally in depression, activity tends to lift mood, tends to improve mood that little bit. In post-exertional malaise and fatigue, there is a significant dip, a significant worsening of a range of symptoms after even minimal activity. So that's one way of differentiating PEM from primary depression. And then we've got the neurocognitive disturbance. So neurocognitive disturbance includes prefrontal cortex. And this is where we look at executive dysfunction and we look at short-term memory, working memory deficits. Then, as part of the overall picture, sleep dysfunction is a specific criteria. So important for us to take a good sleep history. So PEM, fatigue, sleep dysfunction, neurocognitive impairment. Then we have pain. And pain is really part of that perceptual domain. Allodynia, hyperalgesia, or just sometimes that fatigue and general malaise, the body aches can mix in with each other. There's also significant headaches. And then we have neuroendocrine dysfunction, the immune dysregulation, and then we also tend to have neuroendocrine dysfunction, and then we have the autonomic nervous dysfunction. So that's the recap of what chronic fatigue syndrome looks like. So take a step back and just think about the domains. You probably have many patients where they fulfill all of it. What tends to happen is when you have a patient with mast cell activation, for example, as a diagnosis, take a step back and think about how the other areas are affected as well. It's the ones that don't respond to those that start moving forward, right? So look at all these other domains, and that's where you'll find those particular clues. And when you take a history, then simply note everything down, and then we build a formulation.